Hereby, I open this academic ceremony in which Jessica Neicun will defend the academic thesis, a 3-level drug epidemiology of novel psychoactive substance use and health-related harms from an international perspective. May I invite you to present a summary of your study and the conclusions of your thesis?
Dear Prorector, dear members of the Corona, dear supervisors, colleagues, and friends, I will present a summary of my PhD dissertation titled The 3-Level Epidemiology of Novel Psychoactive Substances Use and Health Harms from an International Perspective. Novel psychoactive substances are natural or synthetic substances that may pose a public health threat, but are not controlled under UN conventions on drugs. Over 1,000 substances were reported to the United Nations Office on Drugs and Crime by December 2021. So there are growing concerns about their risk and long-term adverse effects on health. In this frame, this research had as an aim to contribute to a debate on a drug policy that goes beyond the mere normative considerations. To this purpose, the general objective was to provide relevant knowledge on NPS use, defining individual, socioeconomic, and structural contributing factors. This was translated into 5 specific objectives. The first one was to describe the NPS use phenomenon, which was possible through the review of the available scientific literature on the use of kratom, which is a plant-based NPS, having a wide range of psychoactive effects and motivation for use. This was published in a book chapter that you can find in chapter 2. This was completed by the identification of individual, behavioral, and socioeconomic contributive factors to NPS use, which was possible through the descriptive and correlation analysis of population data coming from the US National Survey on Drug Use and Health, covering the period between 2007 and 2017. This was published in 2 peer-reviewed articles that you can find in chapter 3 and 4. The third objective was to describe contextual factors associated with NPS use, notably the opioid prescription practices that could create the conditions for an opioid crisis in Europe. This was made through a systematic review of 12 articles covering the period between 1985 and 2016. We analyzed insurance data from Germany, which is the largest economy in Europe and the most populated country. We described socioeconomic characteristics of people receiving opioid prescription, but also diagnosis, prevalence, and trends of use. This was published in an article that you can find in chapter 5. The fourth objective was to describe the legal and policy measures adopted in Europe to counter the emergence of NPS, which was made through an scoping review covering 145 legal acts and policy documents released by 6 European countries between 2010 and 2017. This was published in an article that you can find in chapter 6. And finally, the assessment of the effectiveness of those legal measures was made through a second scoping review covering 113 legal acts and policy documents released by 10 European countries between 2010 and 2021, along with the analysis of the epidemiological and administrative data on NPS use, intoxications, and related deaths. This was published in a last article that you can find in chapter 7. But to understand the NPS use phenomenon, we use a combination of 3 drug epidemiology streams. The first one focuses on individual factors, so mainly motivations, but also positive and negative influences of drug use on individual health, which is called the positive drug epidemiology. Second focuses on socioeconomic factors that explain drug use behaviors, but also drug-related health outcomes. This is called the social drug epidemiology. And the third one is the legal drug epidemiology, which focuses on the legal and policy measures that have an influence on the structural conditions or factors within which MPS use occurs. Our findings show that MPS are used to replace or to boost the psychoactive effects of traditional drugs. So the most commonly used are hallucinogens like tryptamines and some phenethylamines, but also stimulants such as synthetic catenones, phenethylamines as well, and also synthetic cannabinoids and some depressants such as benzodiazepine and especially novel synthetic opioids. We have also observed that there has been an overall increase in the lifetime prevalence of MPS use over the last 15 years, even though there is a stagnation observed lately, mostly in high-income countries, but also in other areas of the world. In terms of intoxications and death, we have observed heterogeneous trends, mainly due to the resilience of the drug market, but also to some measures implemented by countries. When it comes to the motivations for MPS use, we can observe positive motivations linked to the pursuit of well-being and pleasurable experiences, but also the need to strengthen sociability. Among negative motivations, we can mention mental and physical health issues, but also the need to cope with life difficulties. These motivations are concomitant with patterns of polydrug use, including illicit and illicit drugs, but also high levels of mental health needs and the misuse of benzodiazepines and opioids. In terms of socioeconomic factors, we observe that MPS use or MPS users may be either socially inserted people, so economic active individuals, or excluded or marginalized populations, including homeless and incarcerated people. In terms of demography, two main groups were identified, one formed for young men in their 20s and the other by adult women in their 40s or older. When they are economically active, MPS users are less well off than the general population. We also observe that non-heterosexual MPS users show higher levels of socioeconomic vulnerability. However, no link was established between socioeconomic vulnerability and MPS use. In terms of legal epidemiology, we observe that the legal control measures adopted by countries had always an effect in the decrease of MPS supply, so a less availability of substances, which is often followed by the emergence of new, more toxic and more potent substances, which result in shifts in drug use patterns. So the blanket bans, the individual listing, or the generic control, or a combination of those that introduced criminal administrative sanctions, had as an effect the partial and temporary prevention of MPS use, but also the increased exposure to health risks and harms, which may be mitigated by public health interventions, such as drug checking, crisis management, and counseling, mostly implemented by community-based organizations. If we combine individual and socioeconomic factors, we can identify at least 4 MPS user profiles. The first is formed by chemsexers, who are socially inserted young men that use drugs, NPS and other stimulant drugs in sexual contexts to facilitate sexual intercourse, but also to enhance sexual pleasure. The second is formed by partygoers and e-psychonauts, who are socially inserted young people who also use drugs to socialize, to explore themselves, but also to enhance the pleasurable experiences they have in recreational settings. The third group is formed by non-medical users of psychoactive medicines, who are mostly women who have to cope with mental and physical health problems. And the fourth is formed by high-risk polydrug users, who are socially excluded adults who use drugs to cope with the difficulties of their daily life. The health risk and harm those groups are exposed to results from different combinations of individual socioeconomic and policy-induced risk factors. Recreational MPS users are exposed to the lack of information on the composition of MPS and also to the very presence of MPS in the drug they consume. In that case, social networks act as protective factors insofar they disseminate information on harm reduction. chemsexers are exposed to bloodborne disease such as HIV and hepatitis C, explained by patterns of injection drug use. But they are also exposed to mental health needs that they don't address at drug services of health services because they are not prepared to treat those health conditions. High-risk polydrug users are exposed to the negative consequences of poverty and socioeconomic inequalities on health in general and also on drug-related health outcomes. They are also limited access to healthcare because of the limited availability of harm reduction across countries. And finally, the non-medical users of psychoactive medicines are exposed to risk linked to the underlying mental and physical health condition they present. And they have very limited access, if any, to drug services because they don't correspond to the classic profile of drug services clients. The implication of these findings in terms of drug policy are mostly related to the fact that restrictive control of drugs favor the spread of MPS. They may partially and temporarily prevent their use, but instead of preventing permanently use, they produce shifts in drug use patterns, which expose individuals to an increased probability of severe adverse effects on health. In terms of public health and clinical practice, there is little knowledge about pharmacological and toxicological MPS profiles. There is also a lack of knowledge about MPS composition in medical settings, which may lead to misdiagnosis, especially in emergency rooms and psychiatric wards. There is also a lack of tailored drug treatment and harm reduction services for MPS users and for high-risk MPS users in particular. Besides, there's also a need to develop new approaches to prescribing psychoactive medicines to avoid their replacement by MPS and other fake medicines. In terms of research and monitoring, there is a lack of reliable data on MPS, notably explained by the differences in terms of policy priorities across countries, but also because of technical capacities and access to funding. This results in an underreporting on MPS use and health hazard, including death. So there is a need to further develop MPS monitoring systems, including epidemiological, clinical, and forensic settings. The main takeaway messages of this research are linked to the fact that personal motivations and preferences instead of legal status of substances are more determinant contributing factors to MPS use, while the exposure to MPS-related health harms depend on different combinations of individual, social, and policy-induced risk factors. Also, the negative MPS-related outcomes that we can observe are worsened by poverty and socioeconomic inequalities, so are more linked to the social determinants of health. Which are the next possible steps? To rethink the punitive approach to drug use and to consider the positive and negative motivations, but also effects of drug use on individual health, which may be possible through the incorporation of more stakeholders into the design and implementation of drug policy and public health programs, which includes drug users themselves, but also healthcare professionals and community-based service providers. Finally, we need to develop research and monitoring systems to reinforce a timely and comprehensive data collection on MPS. Thank you for your attention.
Thank you very much for this very clear and concise presentation. And so we will now go over to the opposition. The opposition will be opened by Professor Wim Groot, who is a professor of health economics at the Department of Health Services Research at Maastricht University, and he was also the chair of the assessment committee. Professor Groot.
Thank you, Mr. Pro-Rector, dear candidate. Let me start by expressing my appreciation for the work that you've done. I think you've written a very insightful dissertation that has greatly expanded our knowledge on NPS use and policies to address these. Your dissertation has resulted in a number of fine publications, and I think also provides the input for policies, for the redesign of policies. And it's on this latter topic that I would appreciate to engage into discussion with you. At various places throughout your dissertation, you provide policy recommendations or advice for a change in policies. For example, if you go to chapter 6 on page 197, there you provide an argument for greater involvement at the European level, at the European Union level, for a more proactive role for the European Union in promoting the implementation of risk minimization measures. When reading that and considering that nationally drug policies are frequently quite controversial, and it's in many countries, especially countries within the European Union, there's very little consensus within society about what policies to advocate and what direction to take in dealing with NPS use. I was wondering why and what benefits it would have to look at the European level to develop and implement policies. I would appreciate if you could explain to me a bit more and reflect a bit more why you think there's added value in taking this to the European level.
Highly esteemed opponent, thank you for your question. This recommendation is based on the role that the European Union, through the European Monitoring Center of Drug and Addiction, has been implementing or playing since a couple of years on the international scene, in terms of promoting more progressive approaches to drug use and implementing since the last drug strategy, the harm reduction as a main pillar of the European drug strategy, which is something that is an innovation in terms of international drug policy, and is also a step forward in terms of implementing or considering the not only the eradication of drug use, but also the reduction of the risk associated with drug use. So that's why I focus on this, because it's something that is already being done and is highly appreciated by all the actors, or many actors involved in the drug policy design and implementation. But I am also aware that this is not something that the MCDDA cannot do by itself, because it has limited attributions. And there is also highly variations in terms of the policy approaches to drugs across Europe. So it's something that it may be done slowly, and probably will face different controversies and difficulties in the further implementation of those harm reduction measures.
I think that the one area angle to approach is how feasible it is to get consensus at the European level on a policy like this among countries. That of course is the basis of all policies within the European Union. The other, what I was curious about, what you think would be the added value of having a European-wide policy in this over the national policies, which you rightly say, I think, above are mostly based on and depend on cultural backgrounds and political priorities. So maybe you could reflect a bit on what you think would be the benefits of having a European policy in this.
I think this is linked to the exactly to the progressive or more progressive approach to drug use that the MCDDA as an European institution has. So it's something that is followed by other actors in the international scene, notably at the UN level, and is also I think that maybe be a support. Probably difficult to implement in some countries, but it's still a support for the community-based and health providers that are pushing for the a sort of implementation of more evidence-based measures that promote the implementation of harm reduction instead of the eradication of drug use. I think that is it's a sort of political role, which is difficult probably to reflect on policy implementation on a short-term view, but it's something that is still. I mean, the European institution through the MCDDA play and has played a role in promoting this approach to incorporate other views on the design and implementation of drug policy.
Okay. I think for the moment I'm satisfied with that answer. I want to move to chapter 7, and at the end of chapter 7 on page 245, you provide another type of policy recommendation, where you say that there is a need for innovative regulatory initiatives that go beyond supranational bodies and state-centered laws, so beyond what should be done at the European level, focusing on dissuading drug use. I was wondering if you could elaborate a bit more what you mean by innovative regulatory initiative. What kind of initiatives are you thinking about then?
I was thinking about the initiative focused on the regulation of drug markets, notably, and to do so to some initiatives that involve other actors apart from the policymakers and government representatives. I was thinking about the initiatives such as that has been implemented at the UN level, involving the community representative of different groups across the world to inform the design and implementation of drug policy. So in that case, I was specifically thinking on in these two steps, I would say. So the involvement of more actors in the design of drug policy, which is an innovation or could be an innovation, but also, and all this, I would say, with the perspective of implementing more regulated markets that have been shown to have an impact, a positive impact in terms of health outcomes.
Okay, I think the pro-rector is signaling that my time for discussion has ended. So I give the word back to the pro-rector.
Thank you very much, Professor Groot. And the opposition will be continued by Professor Keith Humphreys. He is Esther Tink Memorial Professor at Stanford University in the United States. Welcome to this session, Professor Humphreys, and the floor is yours.
Thank you, Pro-Rector. And thank you, I would say, for the opportunity to read this dissertation. It was, I thought it focused on a very important issue, and I also grateful to you for the clear exposition you just gave of your key findings. I'm going to go on the same line as Dr. Hoot and just ask more about the policy implications. So, as you know, Our entire system of international drug control, which we've had for over 100 years, that almost every nation on earth signed up for, including yours and mine, was based on the assumption that somewhere there's a farm, somewhere there is a plant growing, and that plant will be processed and it will be transferred from one country to another. And the drugs you're studying, certainly, kratom is a plant, but for the most part, these aren't plants, and they can be synthesized, in a small lab in the same country where people consume them. So what do you think this means for the future of international work in drug policy supply control? Does it need to be rethought, this concept that we'll always be dealing with agriculture, or not?
Hi, Tim O'Brien. Thank you for your question. I think this issue is more linked to another aspect to the policy or the drug policy design, which involves the socioeconomic effects or the socioeconomic side of the drug problem in general. What I mean by that is that the fact is if the countries where the psychoactive plants are produced are in the so-called global south, and there is a sort of mechanism that also apply to other commodities in general, in terms of the transfer of raw materials from less developed country to be transformed in highly industrialized countries. So I think the main problem of this is not only about drugs; it's a more development problem about the economy, the functioning of the global economy as well, because drugs are a very important component in terms of economic production. So I think this may be the step to take in this regard, and this is something that has been shown in terms of the failure of the eradication plans implemented in Colombia, which were supported by technical support to help producers to transfer to another crops. So this is something that may be addressed when we think about a new or innovative drug policy. The socioeconomic development problem linked to the production and to the production and to the transformation of those substances may be involved, and the economic implication of this transformation we could promote may be considered and support by financial also components.
Mm-hmm. Well, thank you. Very interesting. Let me ask you another policy question, again, to follow up on Dr. Hot's comments. So you recommend harm reduction and a Europe-wide approach. And there may not be consensus on that, but let's imagine that there were consensus, that all the EU nations agree that was the right thing to do. Do we actually know how to do that? Most harm reduction that works was developed for people who inject opiates. We have multiple effective programs for that population of people. But do we know what we're doing with NPS and harm reduction?
I think we could count on the community-based service providers who are already in many European countries providing harm reduction services to recreational NPS users and other users of other drugs as well. So this is something that has been provided for a couple of years in Portugal and in Spain, in France as well, and in other countries. So I think to develop this harm reduction component of a drug policy, the implication and the involvement of community-based organizations that have already been done this work and could be more further developed could be essential. I mean, and then they are involved also with directly involved with drug users themselves to better know how to implement those tailored drug treatment and harm reduction services.
Yeah, I agree with you that there already is engagement around that by the groups you're talking about and the services you're talking about. What I was wondering is your judgment as a scientist that what they're doing is working?
I think so, because there is many, they have been implemented, so some evaluations of the interventions that have been implemented. And they showed a sort of positive results in terms of the prevention of adverse episodes, because they check the drugs before people consume it, and also because they provide inside clinical emergency management. So I think this is a small scale so far, but it's something that has been proved to be effective.
Thank you. And I think I have time for one more question. So I wanted to ask you, as you know, in public health, we often rely on information campaigns about all kinds of things to tell the population about risks that they might be exposed to. The thing about a lot of these NPS, as you know and you document very well, is that they're pretty obscure to most people. There's new drugs every week. People wouldn't necessarily have heard of them. Few people use any given one. How do you craft a public information campaign that informs people about what the risks are of new NPS, without at the same time having the potentially negative effect of telling a bunch of people who didn't know about this new drug that it's out there and then they might use it?
I think that is something that may be addressed. I think there are people that are more sensitive to or they are less exposed to the motivation for drug use. This is something that we cannot, I don't think that the dissemination of public information about the very existence of this drug may necessarily provoke a sort of wider interest for using those drugs. This is something, I think it may be comparable to the fact that, for instance, in countries where the the recreational use of cannabis has been authorized, there were concerns about the fact that that would be a sort of appealing, to increase the use of cannabis. And what have been observed is that there may be a increase in the recreation or the experimental, use of cannabis, but not necessarily on a sort of long-term use of cannabis. So I think this logic may be applied to the NPS, and I think that it's not necessarily a negative things to inform people of the very existence of these drugs, but also we have to, and this had been done once again by community-based organizations, about the risk they may face. And I think this is something that people had already reported to be something that prevents them to use the drugs.
Thank you. That makes a lot of sense to me. I believe I'm at the end of my time. Thank you very much for your answers.
Thank you, Professor Humphreys. The opposition will be continued by Professor Krzysztof Kajewski. He's a professor at the Department of Criminology at the Jagiellonian University in Poland. Welcome, Professor Kajewski. The floor is yours. Please make sure to unmute.
Done. Thank you, Director. I would like also to congratulate the candidate for very interesting thesis, very well written, and regarding a very important problem in the area of drug policy, especially from the perspective of some countries. And I think that Poland belongs to those countries which were facing a special problems with NPS. Let me ask you a first question, and I would like to refer to the very first page of your introductory chapter where you mentioned the definition of new psychoactive substances, which is used by the United Nations Office on Drugs and Crime. And it says the following: substances of abuse, either in pure form or preparation, that are not controlled by the 1961 Convention on substances. This is some sort of working definition.
I think Professor Korjewski has some internet problems.
Can you hear me?
Yes, you were interrupted, but luckily we prepared the fact that you might have some internet problems. And I would like to invite Professor Wim Groot to take the floor here and to ask the question that you have prepared, since it's very hard to understand from the perspective of the candidate.
First question, yeah.
Professor Groot.
Yeah, I'm afraid I don't see the question in the chat anymore. I don't know what has happened here.
It's the first one. I see it on the chat.
Yeah, I saw you wrote it in the chat, but
So we can try.
I have it here. Yeah.
Okay.
The first question are the definitions of NPS provided by the United Nations, and referring to the fact that NPS are substances not listed under the UN conventions, a sufficient definition? If an NPS gets listed, does it cease to be an NPS?
Highly esteemed opponent, thank you for your question. I think this is the very high controversies about the definitions of NPS itself. So this is one, the one I use in my introduction, and the one I use in the presentation today as well. But there are many voices that contest this definition, and also there are many definitions of NPS themselves. So I think from my perspective, the main issues is not necessarily the legal status of substances, because some substances are considered, as ketamine, are considered as NPS, and they are used for medical purposes for several years and decades. And there are also new substances that emerge and they are placed under control, but they are still considered as NPS. So the fact is that this definition is very fluctuant, I would say, and depends on different factors. Some policymakers or some countries have defined it by the very effect on the psychoactive effect they may have, or the effect they may have in the central nervous system. So I think that all the definitions may be not necessarily exclusive of each other, but the main aspects are on the legal status, which can be modified by law or by regulations. That is something that helps people to, or not help, but may have an influence on the decision of taking this drug. And the other is the fact that they have a psychoactive substance effect that emulate the classic recreational or the classic drugs that are used for recreational purposes. But lately, we have also observed that people that look for the substitution of the psychoactive medicines also use NPS. So I think all these different definitions of NPS may be sort of summarized on the fact that they may be control or not, which has an influence on the availability of those substances, and the fact that they have psychoactive effects that emulate classic psychoactive drugs that people use.
may I interrupt you? From the point of view of the essence, let's say, of the problem, what is the nature of the problem with NPS? Why are they so problematic? Because of the control. But why do NPS are created?
They are so, from my perspective, they are so problematic because they are more potent and more toxic than the
that's from the pharmacological, toxicological point of view. From the point of view of the control, why do they produce NPS? What is the original idea behind those substances?
If I understand well your question, because the internet is very unstable, I think the from the policy perspective is the fact
Okay,
that
let's forget it. Probably you will read my question.
sorry.
Well, thank you. Well, let's switch to the second question because it really this connection seems to be problematic. Professor Gross, could you read my second question?
Yes. You differentiate between various methods of controlling NPS, like general listing or specific NPS legislation. But various ways to regulate is one issue. The other is how to react to violations of the laws. Can you eventually indicate various approaches to this issue? Is penal sanction the only available means?
Well, what has been observed through the implementation of all these ways of regulation in NPS is that in some countries there are variations as well, not only on the modalities of legal control implemented, but also on the introduction of criminal or administrative sanctions, and on the focus on the possession and use of substances, but also on the focus on the commercialization or the trafficking of those substances. I think there are definitely differences in terms of the approaches to drug use in general and to NPS in particular. But what has been shown, and in Poland is one example of that, that even the combination of criminal and administrative sanctions all usually produce what is called the cat and mouse game, which means that the drug market is resilient enough to circumvent these new measures implemented and to produce new substances that replace the controlled one. So I think in terms of the ultimate effect that this dissertation is interested in, which is the availability of substances that may have an impact on the health of users, different combination of legal measures at different states or under the umbrella of different paradigms in terms of legal measures, had all as an effect more or less the same dynamics in terms of the interaction with the drug market dynamics.
Thank you very much. I think I have exhausted my time. Therefore, thank you again, and thank you, Rector. And I think the next is on the road.
Thank you very much, Professor Kojewski. And this was a positive effect of good preparation that we had in the pre-session. And thank you very much for the improvisation, Professor Groot, and also for your cooperation, dear candidate. So the opposition will be continued now. by Dr. Kim Kuipers. She's an associate professor at the Faculty of Psychology and at this Maastricht University. The floor is yours, Dr. Kuipers.
Thank you, Prorector. Dear candidates, also I would like to congratulate you and your team with this milestone, your beautiful dissertation. I think it also has to be mentioned that you worked through the Corona period, very difficult period, and you also published and presented your work. You gave a lot of presentations. And I also read that before you started your PhD trajectory, you were also working, already working in the field, which has to be applauded, I think. But let's move on to business, where we are here for. So I not only read your dissertation, but I also read your propositions, also with a lot of pleasure. I think it always gives a good insight in the mind of the author. And my attention was drawn to your proposition 5. And my question would be whether you could read it and explain it. I want to know how we can approach what you state in proposition 5. And I also want to hear from you which research, in your view, is pivotal for mental health, which cannot be conducted today due to the restrictions you mentioned.
So, highly esteemed opponent, thank you for your question. So my proposition number 5 states that the control of an increasing number of psychoactive substances, limited research on all new substances whose potential therapeutic benefit and actual harm potential remain unexplored due to licensing requirements. This refers to the fact that the placement under control of substances is not only focused or has as an intention to prevent the use of the substances, but also prevent the use for scientific purposes, and which a good example of this is what happened with cannabis, which is placed under control for decades, and all the positive or potential positive uses of different components of the cannabis plant have been also prohibited by the fact that this plant is under control. So this is the problem. I think this is a problem when a substance is placed under control. All the research, not only about the therapeutical uses, potential therapeutical uses it may have. This is the place also, or the case also about other NPS or plant-based NPS such as kratom and cat, but also about the very or the toxicological and pharmacological profiles of these substances that may pose a public health threat. So they are both lines are I would say impacted in a negative way when the substance is under control. This is what I say that.
Yeah, I'm asking because this is my field of research. We do placebo-controlled studies with NPS, so substances that are controlled. So I was wondering which research you think is now lacking, which is pivotal for mental health, and that we cannot do now.
I think the most important are those the research that is focused on the substance that have already identified or may have potential, triggering effect on psychotic episodes. So this is the mostly the case of synthetic cannabinoids, but there are also other hallucinogens that may have this side effect. So I think this is something that may be, focus the research at this moment in terms of mental health and health in general, because of the high level of mental health issues that NPS users seem to have. I think it's very important to focus on that, because the the negative effect that may have on the triggering of psychotic effects of people that are not aware that may be, vulnerable to these situations. So this is something for the cannabis has already been identified as a risk factor. Synthetic cannabinoids are more dangerous in this regard.
So more survey research then.
More survey research are also, I think, pharmacological research on the effects, the possible effects of on mental health of these substances.
Yeah, okay, thank you. Then I want to move on to another question. I saw that you also mentioned it on one of your slides. You state that national monitoring systems do not focus on NPS use, and there is a need to develop these systems further. And I want to hear from you how you would approach that.
I think it would be simply addressed by the fact of including questions about the prevalence of NPS use in national surveys of drugs, which is not the case in all countries. It has been incorporated slowly by different countries, but in many cases, they may focus on one type of synthetic drugs. That is the case, for instance, of France, who only asks about the use of synthetic cannabinoids and don't investigate about the use of other NPS who are under control in the country. So I think this may be further developed. Start by the inclusion of the use of NPS in population-based drug surveys, but also the specification of at least the main categories of NPS that people may be exposed to.
Yes, thank you. I give the word back to the program.
Thank you, Dr. Kuipers, who is also the secretary of the session today. Thank you very much for that, Dr. Kuipers. And the opposition will be continued by Dr. Timo Clemens. He is an assistant professor at the Department of International Health of Maastricht University. Dr. Clemens.
Thank you very much, dear Pro-Rector, dear candidates, dear Jessica. I would like to congratulate you as well to the achievement of the PhD manuscript and significant contribution to the research on NPS. And I would like you to congratulate as well to a very clear presentation at the very beginning. I thought this was well designed as well. And let me extend my congratulations to your family and your promotion team as well. One of the aspects that I really appreciated in your work was the three-level drug epidemiology perspective that you took. And my first question relates to the social drug epidemiology perspective and the chapter on substance use among sexual minority. If I'm not mistaken, that's chapter 4. So you investigated there the relationship between a self-rated belonging to a sexual minority and drug use. And I wanted to relate or exchange with you on in how far you consider this, what kind of quality this social perspective and belonging to a minority has in order to affect the NPS use. Because if you look into the work of Sandro Galea, who has spearheaded some of this work, there's often been, from a social drug epidemiology perspective, rather about the quality of relationships that then impacted uptake of drug use or not. So in how far do you consider sexual minority belonging as a social determinant, and what is the quality of belonging to that minority?
Alice Tim Opponent, thank you for your question. I think your question is very broad. I will try to address the different topic you refer to. I will start by the fact that the social epidemiology is certainly a stream or epidemiology stream that encompasses much more aspect than the one that I could address or explore through my dissertation. Notably, the relation with the community, the family and the community, not only the individual related or the individual level socioeconomic factors, which I explore in my dissertation, but also the relation with the environment. And this is something that is very challenging for the study of MPS, because, as I said, there is no, or at the time I started my PhD research and throughout time, there's still lack of in population-based data. So epidemiological data, including longitudinal studies that could inform a broader approach, a social epidemiology of MPS use. This is linked to the previous question of the previous opponent related to the fact that MPS are not included in most countries in the population-based or national drug services, or drug surveys. So this is one thing. And the other thing is that based on our literature review, we have observed that there were all sexual minorities were of particular interest in terms of the use of MPS, mostly linked to the fact that the patterns of injecting drug use they present. So this is something that was motivated by the review of the literature, and in terms of the contribution of what we have done, is the fact that we explore based on population-based data from the US, this individual level socioeconomic factor of a particular group of people that have been identified prior to this research as a group of concern in terms of all the negative health outcomes that the drug use patterns has as a consequence. So this is something we think that, or I think that this dissertation provided some new information that was lacking at the moment about the particular socioeconomic individual factors that are linked to a specific group of concern identified by the research in the field.
But then let me come back to the second part of my question on the quality of the social relationship, because let's say generally social drug epidemiology would assume there is a social factor, it causes stress or it relieves stress, and that has then an impact on drug uptake, drug use. So how do you see the mere fact as belonging to a social minority being having that quality in terms of a stressful relationship or supporting that uptake or not?
I think that is a more psychological, aspect of the problem, which is not addressed in this dissertation, but it's linked to, as you say, to the interaction with the community, with the family, and with the society as a whole, and the stress that sexual minorities face in different social contexts. So this sort of internalization of the stigmatization of sexual orientation is an underlying factor to mental health issues and also to the drug use patterns. So I think that this is the core of the problem. As I said, this psychosocial aspect were not addressed by this research because it's more, I think it could be, and other scholars in the field have already started this work, in terms of the qualitative, research that has to be conducted to better understand how this the internalization of stigmatization have an impact on the mental health and the drug use pattern of sexual minorities and other groups, racialized people also in some contexts.
Laura asks,
Jessica Neicun, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations on our return. Jessica Neicun. The degree committee here present online has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Chabanowska is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Thank you, Prorector. Dear Jessica Neicun, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible? Unmute yourself.
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Jessica Neicun, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university, shown by the beadle. And now I would like to read a short laudation to you, Jessica. Dear Dr. Jessica, dear Jessica, it has been a great pleasure to accompany you throughout this pioneering PhD journey to discover the complexities of prevalence, use, epidemiology, and hazards of novel psychoactive substances, which you made sure to be academically interesting, rich, and fulfilling. Reflecting on your work, which resulted in this great accomplishment, I could clearly see 4 characteristics that epitomize your achievement. And these are commitment, engagement, scientific curiosity, and perseverance. Commitment is a very strong asset. You chose the topic of your PhD and you're fully immersed in it. You have been building and expanding your knowledge by engaging in different research teams, activities which created trust around your work and passion. I will always remember your first presentation at the Salzburg seminar on public health law. The presentation was very good, but it was not the presentation that made an impact on me, but the way you answered questions from the audience, showing your commitment to knowledge and in the field. Since then, I knew you will do well in your dissertation. Engagement is another quality that I admire in you. You helped us develop the course on public health leadership by elaborating on the area related to drug use and addiction. Throughout your PhD, you engaged in teaching by giving a lecture to our master students. You tutored in the course on public health law and developed a case study in relation to your topic, leading the students to propose a policy change and subsequently write a policy brief. 3 groups of students, which you supervised, have published 3 policy briefs. I have always seen the detailed feedback and support that you gave to our students. Curiosity, scientific curiosity is also your strong area. I could observe how passionate you are about new academic developments in the field, reaching out to colleagues, collaborating with MCDA, and investigating the differences between countries and their legal approaches and trends and policies in relation to illicit drug use. It was so powerful to hear you say that you have developed your theoretical approach of 3-level drug epidemiology. You explained it in depth to me, and I have learned a lot from you. Thank you, Jessica, for this. And perseverance is a quality which is very important when you aim at reaching your goal or professional success. There have been several changes in your life. You changed jobs, working languages and countries, and with each change, you grew stronger and always managed to concentrate on opportunities rather than threats. Currently working as a researcher in your field in Montreal, Canada, and you are an important asset for the research team. Dear Jessica, I'm very proud of you and your work as your supervisor and promoter. You have also been an inspiration for your fellow PhD students who could see your growth and participate in the evolution of your thesis. I would like to congratulate you and your closest family and friends who supported you in this journey. I hope we'll continue our academic collaboration and that it is not the end of our journey. Now, I would like to move to Dr. Andres Roman Urestarazu to say a few words. Thank you.
Thank you very much, Professor Shablanska. So the first thing I wanted to say in a less formal way is to congratulate you, Dr. Neicun. I think it's been a long journey, a good journey. And I think, and I hope as well that it's been something that you have enjoyed as much as you have worked so hard to achieve this. I also think that, of course, we will continue working. This is just the beginning, as I usually tell students that I have supervised. And also congratulations for developing a research career now in Canada with very interesting work that you're doing, of course, in substance abuse and alcohol abuse in First Nations. I think that's very pertinent work. Of course, the doors are always going to be open for any future collaboration in continuing this intellectual journey together. So thank you very much for having given us the opportunity to supervise you and work together. Congratulations once more, and thank you very much for the journey, and good luck with all the things to come.
Dear Dr. Neicun, also on behalf of Maastricht University, I would really like to congratulate you on the degree that you have acquired. And with that, I would also like to include your family and friends and congratulate them all on your great achievement. It has not been easy to do the ceremony online, but I think you managed very well and in defending your thesis. So also my congratulations on that. Saying that, I hereby declare this ceremony ended.